Good day, friends. I am talking to you from India, and it is the afternoon in the UAE, and it could be morning in several other parts of the world. So, good day, friends. Now, this is our third DiaBeat webinar. Our first webinar was managing diabetes. Our second webinar was on the diabetic diet. And today we have an interesting topic, clinical edge, the metabolic syndrome. I will give you my impression of what I think that means, and our renowned speaker will talk about this later in the afternoon. As is my habit, and I've mentioned this before, I usually read up a little bit on the topic, and I discovered, or I rediscovered, that metabolic syndrome was a combination of factors, a combination of several factors that included abdominal obesity, high blood pressure, high blood sugar perhaps, high triglycerides, high levels of bad cholesterol or low levels of good cholesterol. And this combination of factors puts you at the highest possible risk for stroke and cardiac ailments, which are two of the biggest killers in the world today. A complex subject. And I tried to look at causes, and the causes to me did not seem sufficiently enunciated. We spoke about family history. We spoke about a sedentary life, excess dietary intake, low levels of exercise activity, poor sleep. But these, I don't think, are the complete answers. We need a specialist to tell us what exactly the metabolic syndrome is and what are the solutions. We have today with us Dr. Hala. Now, Dr. Hala is the head of endocrinology, in RAC hospitals. She is an MB, BCH, MS, MRCP from the UK and an SCE in endocrinology. Now, Dr. Hala Hamdi did her master's degree in 1987 and got her MRCP in 1999. In 211, she specialized in endocrinology and diabetes and has a cumulative experience of over 30 years working in several countries around the world, including Egypt, Kuwait, and the UAE. Ladies and gentlemen, I could think of no other more knowledgeable individual in our institution to talk about the metabolic syndrome than Dr. Hala. Dr. Hala, by the way, is also a member of the technical committee of the RAC Diabetes Challenge, and it is due to her vision that we have put together the methodology by which we will decide the winner, which includes, according to her, 3 aspects: control of HbA1c, management of weight, and management of lifestyle. This is the Dr. Hala philosophy for the RAC Diabetes Challenge. Ladies and gentlemen, I present you our speaker, Dr. Hala.
Good afternoon, everybody, and thank you, Dr. Kennedy, for this introduction. We'll speak today about the metabolic syndrome. The clinical edge. What we mean by the clinical edge, this is what we will show you in these preceding slides. The metabolic syndrome is a major and escalating public and clinical challenge worldwide in the wake of urbanization, surplus energy intake, increasing obesity, and sedentary life habits. Metabolic syndrome has a 5-fold increase in the risk of type 2 diabetes and 2-fold the risk of developing cardiovascular disease over the next 5 years. Worldwide prevalence of metabolic syndrome ranges from 10% to 84%, depending on the region, urban or rural environment. The International Diabetes Federation estimates that 1/4 of the world adult population has metabolic syndrome. Higher socioeconomic status, sedentary lifestyle, and high body mass index were significantly associated with the metabolic syndrome. 1 in 3 adults having metabolic syndrome. Family predisposition, aging, obesity, chronic high-risk food choices, sedentary lifestyle, hypertension, and polycystic ovary syndrome in ladies, preeclampsia, ethnic as Hispanic and South Asian, obesity. All of these are risk factors for developing metabolic syndrome. So what is metabolic syndrome? Metabolic syndrome is defined by a constellation of an interconnected physiological, biochemical, clinical, and metabolic factors that directly increase the risk of atherosclerotic cardiovascular disease, type 2 diabetes mellitus, and all causes of mortality. So metabolic syndrome, there will be high blood sugar, high blood pressure, high lipids, large weight size. What are the numbers to define it? This slide showing the evolution of the metabolic syndrome diagnostic definitions throughout the years. And now the International Diabetic Federation defines it by 3 or more criteria, and one of which should be the central obesity. So the waist circumference, we mean it the central obesity. It will be more than 40 inches in men or more than 35 in women, plus 2 other criteria at least. High density lipoprotein, less than 40 milligram per deciliter in men and less than 50 milligram deciliter in women. Triglycerides, more than 150 milligram per deciliter. The fasting blood sugar, more than 100 milligram per deciliter, or high blood pressure, more than 130 over 85 millimeter. So the central obesity, it comes by measuring the waist circumference. So metabolic syndrome negatively impacts your metabolic activities and puts you at a greater risk of a stroke, heart diseases, and type 2 diabetes. Obesity. Obesity is the most common risk factor of metabolic syndrome, especially the central obesity, which reflects the visceral adiposity. And the visceral adiposity is the main factor contributing to the metabolic syndrome. So if not checked on time, puts you at the risk of type 2 diabetes, heart diseases, heart attacks, or stroke. Adipose tissue was initially classified as energy storage organ, but today it is known to function as a major endocrine system that secretes adipokines, growth factor, cytokines, and chemokines. In obesity, the adipocytes we mean by the adipocytes, this is the fat cells. They are dysfunctional with excessive secretion of multiple pro-inflammatory adipocytokines, continuing to a chronic inflammatory reaction and promote the progression of metabolic and cardiovascular complications. This is the insulin resistance. So you eat food, pancreas makes the insulin, but the cells resist the insulin. And so sugar stores as fat. You feel tired and hungry again. And this is a viscous circle. Insulin resistance is not only involved in the etiology of type 2 diabetes, but also that of the cardiovascular disease. So as we said, to define the metabolic syndrome, 3 criteria, which one of them is the waist circumference. Fasting blood sugar more than 100, blood pressure more than 130/85, triglycerides more than 150 milligram. The good cholesterol below 40 milligram in men and below 50 milligram deciliter in women. Skin patches, this is the dark velvety skin called acanthosis nigricans on the neck, the groin, and armpits, which frequently found in insulin resistance patients. And add this diagram showing us high carbs diet, constant high glucose in the blood, constant insulin demand, pancreas secretes more, but the cells and the insulin receptors are resistant to this insulin. So starving cells with high glucose level, with high insulin level, leads to more hungry and other health problems. What is acanthosis nigricans? The exact mechanism is unknown, thought to be a manifestation of insulin resistance. High concentrations of insulin may stimulate growth factor receptors on the keratinocytes, promoting the epidermal cell proliferation. This is the picture nearby of the acanthosis nigricans. As we said, that the fats act as an endocrine system, secreting many cytokines like adiponectin, leptin resistance, fibrogen growth factor, tumor necrosis factor, interleukin-6. So in metabolic syndrome, you will see that there is decreased adiponectin. And so if adiponectin is decreased, there will be increased the weight, increase the adiposity, increase the inflammatory cytokines, hurts the kidneys, increase the RAS stimulation, and all these increase the insulin resistance. There will be increased leptin, but this leptin is not working due to the leptin resistance. With decreased satiety, with increased hunger, increase the cancer risk, increase the pain, increase the weight. So increase the insulin resistance causes 3 times greater rise in body weight than an increase in the fasting blood sugar. And that is why weight gain precedes the presentation of type 2 diabetes. In an insulin-resistant person, the normal levels of the insulin do not have the same effect in controlling blood glucose level. So during the compensated phase, insulin levels are higher and the blood glucose are still maintained. If the compensatory insulin secretion fails, then either the fasting or the postprandial blood glucose concentration increases. And this is what we call the pre-diabetic state. So usually insulin resistance state comes first with the hyperinsulinemia and the insulin resistance, then the pre-diabetic, then following by the diabetic if not well controlled. So how dyslipidemia is related to the insulin resistance? The insulin normally suppresses lipolysis in the adipocytes. So an impaired insulin increases lipolysis, resulting in the increase the free fatty acid in blood. In the liver, the free fatty acids serve as a substrate for the synthesis of the triglycerides. So because of that, the triglycerides are raised. Insulin also normally degrades the ApoB, so an insulin resistance directly increases the very low density lipoprotein production. The very low density lipoprotein production is cleared by the activity of the lipoprotein lipase. And in metabolic syndrome, and when there is insulin resistance, there is the activity of this lipoprotein lipase is suppressed. So the very low density lipoprotein is metabolized to remnant lipoproteins and small dense low density lipoprotein, both of which can promote the atheroma formation. And with the atheroma formation, this increases the cardiovascular risk of heart disease and strokes. So what are the factors influencing the insulin resistance? Diet. It is well known that insulin resistance commonly coexists with obesity. Saturated fat appears to be the most effective at producing insulin resistance. High-fat diet had the tendency to result in calorie intake that is far in excess from our energy needs, resulting in rapid weight gain. Insulin resistance is probably correlated with the fat intake and negatively correlated with dietary fiber intake. Because of that, we always encourage to eat more fibers. The UK health guidelines recommend that the average man should eat no more than 30 grams of saturated fat a day. The average woman should eat no more than 20 grams of saturated fat a day. It is also recommended that people should reduce their overall fat intake and replace saturated fat with some unsaturated fat, including omega-3. So to compare, you have to compare food labels when you shop, so you can choose foods that are lower in fat, choose lower fat or reduced fat, grill, bake, steam food rather than frying or roasting, measure oil with a teaspoon to control the amount you use, or use an oil spray, trim the visible fat and take the skin off meat and poultry before cooking or eating. The polyunsaturated fatty acids. In the long term, diet had the potential to change the ratio of polyunsaturated to saturated phospholipids in the cell membrane and changing the cell membrane fluidity. It is hypothesized that increasing the cell membrane fluidity by increasing the polyunsaturated fatty acids concentration might result in an enhanced number of insulin receptors and reduce the insulin resistance. So this is the polyunsaturated fats. They are found in high concentrations in sunflower, corn, soybean, flaxseed oils, walnuts, flax seeds, fish, canola oil. Also, the canola oil through higher on the monounsaturated fat. It's also a good source of polyunsaturated fat, like the olive oil, which also contains higher concentration of the monounsaturated fats. So again, as we said, the increased free fatty acid level in the plasma increase the triglycerides enriched very low density lipoprotein secretion by the liver, increase the oxidative stress and endothelial dysfunction leading to atherosclerotic disease. And what is the relation between metabolic and why it is causing hypertension? Essential hypertension is frequently associated with obesity, glucose intolerance, and dyslipidemia. Both hyperglycemia and hyperinsulinemia activate the renin-angiotensin system by increasing the expression of the angiotensin gene, angiotensin 2, and the angiotensin 1 receptor, which may contribute to the development of hypertension in patients with insulin resistance. Also, insulin resistance and hyperinsulinemia leads to sympathetic nervous system accumulation. As a result, the kidney increase the sodium reabsorption, the heart increase the cardiac output, and arteries responds with vasoconstriction, resulting in hypertension. Because of that, in obesity, we always search for hypertension, for lipids, high lipids and sugar. They are all interconnected through this insulin resistance mechanism. So in insulin resistance, either it is a compensatory hyperinsulinemia, in which there will be insulin resistance syndrome with hypertension, stroke, polycystic ovary, non-alcoholic fatty liver disease, or it is inadequate insulin response leading to type 2 diabetes with retinopathy, nephropathy, neuropathy, and both lead to the cardiovascular diseases. You cannot talk about metabolic syndrome without talking about non-alcoholic fatty liver disease. It is the hepatic manifestation of the metabolic syndrome. And nowadays we see it very, very common. And the most common risk factors for the non-alcoholic fatty liver disease is obesity, metabolic syndrome, type 2 diabetes, insulin resistance, dyslipidemia, rapid weight loss and refeeding, bariatric surgery and rapid weight regain, hypogonadism, polycystic ovary disease. All these factors are leading to the non-alcoholic fatty liver disease. What we will do for this metabolic syndrome and the non-alcoholic fatty liver disease? Lifestyle interventions. Lifestyle interventions is the most important factor in attacking this metabolic syndrome. Weight loss, cardiovascular risk prevention, nutritional therapy and food considerations, physical activity for weight loss and cardiovascular health, reduce the insulin resistance and the hyperglycemia. So preventive measures for metabolic syndrome: exercise, do a brisk walk for 30 minutes to 1 hour daily. Have a lot of green vegetables in your diet, along with fruits, whole grains, and high fiber protein. Maintain a healthy body weight. Smoking cessation, of course. So weight loss, 3 to 5% weight loss improves your blood pressure, your lipids, glycemic control, and liver steatosis. 9 to 10% weight loss improve the liver necrosis and inflammation. More than 10% body weight loss further reduce the cardiovascular risk and a variety of inflammatory conditions. Exercise improves the cardiopulmonary fitness. Moderate levels of cardiorespiratory fitness can substantially reduce the mortality risks associated with the overweight and obesity. So what exercise? Any exercise. Aerobic exercise 3 to 5 days per week. Continuous or intermittent aerobic activity for 20 to 6 minutes. 2 to 10 minutes bouts throughout the day. Just move. Resistance training, isometric, weights, flexibility training, yoga, stretching. When you are up, stand more, move more. Improve the cardiopulmonary oxygen utilization. Improve the insulin sensitivity. Helps hyperglycemia and fatty liver. Treat the underlying cardiovascular risk. Manage hypertension to achieve the blood pressure goals. Manage your dyslipidemia to achieve your low density lipoprotein, high density and triglycerides goals. So we can use statins, high dose omega. Consider antiplatelet therapy if needed. Cardiovascular workup and look for the microalbuminuria, which is now suggested as a risk factor for cardiovascular disease. Smoking cessation is very important. So we'll try all this, but still, if it is not succeeded, then maybe we'll need some pharmacotherapy for the insulin resistance and hyperglycemia, like metformin, which decrease the hepatic gluconeogenesis, decrease the insulin resistance, reduce the gut glucose absorption. We can use the pioglitazone or the glucagon like peptide agonists, like liraglutide, semaglutide, dulaglutide, which have a good also for the cardiac condition. And if this fails, then the last resort will be for us the bariatric surgery, whatever it is, a sleeve gastrectomy or a bypass. which we hope you can overcome the obesity by dieting, exercising first. Then we will add these other maneuvers later on if we don't succeed. Thank you for your attention.
Thank you, Dr. Hala. Thank you for your words of wisdom. And those words of wisdom don't come easy. Dr. Hala has more than 30 years of working experience in diabetes and endocrine disorders. She deals with the management of gestational diabetes and diabetic comorbidities, such as hypertension, dyslipidemia, and obesity. Hala is knowledgeable and treats pituitary disorders, metabolic disorders, adrenal disorders, and polycystic ovarian syndrome. Great words of wisdom, not only in the pharmacology aspect, but also in the lifestyle aspect, in the total aspect of metabolic syndrome. Thank you so much, Dr. Hala. And now we have Dr. Wilku, who may want to present a few more questions for Dr. Hala.
Thank you, Professor. First of all, thank you, Dr. Hala, for a wonderful presentation for a clinic. We literally were confused what exactly will be the clinical edge. So you have very carefully drafted it. There are a few questions which we have received the emails also. Now in the chat box also we are getting that. Harsehet is asking, as you mentioned, there is a connection between hypertension medication and diabetes. Does it increase the risk of diabetes? Dr. Hala.
Hypertension is increased due to the metabolic syndrome, not because of the medicine of the sugar. Medicine of the sugar has no relation to increase the incidence of hypertension. Hypertension, the essential hypertension, okay, we have, of course, the genetic hereditary causes, and also the obesity, as we said, with the insulin resistance, it may increase the incidence of the hypertension, but not the medications of the sugar. It is the association of the hypertension. Yes, it happens with sugar, but not because of the diabetes itself, because of the insulin resistance.
Okay, it's a combination of metabolic syndrome. So there is another question from Harsaj, and which I think it's a similar question Serena is also asking. How to overcome the insulin resistance?
This is the clue. The clue is the style life modification, to try to reduce your weight, eat healthy food, exercises, and then if it is not working, then we will add pharmacotherapy, as I said, or bariatric surgery. It needs a hard work. It is not an easy issue.
Yeah, true. And Dr. Vina is asking the role of genetics in type 2 diabetes.
Yes, of course, there is a hereditary predisposition in type 2 diabetes, as all we know. Because of that, you ask about the family history. Family history plays a great role.
Yeah, true. Bharat Rathore is asking, my age is 32. He's a participant in RDC and has checked his HbA1c, which was 5.9%. His cholesterol is high. He's taking Lipitor. What do you suggest for him?
Okay, 5.9, that means that he is pre-diabetic.
Pre-diabetic, yeah.
Yeah, so as we said, he has to take care of his food very much. He has to exercise, and he has to follow his HbA1c to see whether it is coming down or not, and to follow his weight. As long as he loses 5% only of his body weight, his HbA1c will be much better.
Yeah, true. Ma'am, we received one email, very interesting email, because you remember last year we did post-COVID rehabilitation. In that we have come across many questions. So one mail from Mr. Joseph came. He is asking, I suffered from diabetes after being COVID positive. His blood glucose was very high and he was put on insulin regime for 3 weeks. Thereafter, he was taking oral medication. The glucose levels are not very high, but sometimes it is out of control. Do I need to resume insulin? That's his question.
It depends how much his HbA1c.
He has not mentioned it, ma'am.
Yeah, the HbA1c, we see in the follow-up, if he gets all the oral medications and still his HbA1c is out of control, then we may add insulin.
So according to HbA1c readings and fluctuation, then he may.
Yes, whether it is it's not only one reading of sugar. We have to see what medicine he is taking, how is his weight, and how is his HbA1c going on by following up.
True, true. And for that, because what I understood in the second line also he mentioned, can I increase my, can I resume my insulin dose? So I think he's asking whether he can do it himself. But
No,
what I will, what you suggest? He has to consult the doctor to check it a proper investigation.
Yes, he has to consult the doctor, do some blood tests, and follow with the doctor. No one can induce like this insulin. This is a very dangerous medicine. It should be under observation and supervision of a doctor.
True. Ma'am, general question which we came across during the challenge first and second day. People are asking, what is the general takeaway message for all pre-diabetic and diabetic for medication, for their lifestyle, and for their monitoring? What should they monitor regularly?
For diabetic patients, you mean?
Yeah, ma'am, those who were coming for the participation in challenge. So many of them were pre-diabetic also, many were non-diabetic on medication also. So most of them were having a similar type of question. What they should monitor regularly?
As usually, we monitor the patients for their weight, their waist size, their blood pressure, their lipids. Every 3 months, we should check their lipids because they are more liable to have hyperdyslipidemia. Their HbA1c every 3 months to see how it is going on.
Okay. Okay. So I think most of the questions what we received is being answered in your presentation. Anything else? If somebody want to ask, please put a question in the chat box. We will take it forward, or we can close. Yeah, one message has there. Saira is asking, her HbA1c is 11, and I have left carbohydrate totally. It's coming low sometimes. I want to know what is the number that is dangerous. When it's low sometime, it's low as 40. I think she is mentioning both the things, HbA1c as well as fasting or random sugar.
11 is a high number. HbA1c 11, this is a high number. And I don't know whether she is taking insulin or not, because if she reaches 40 milligram, most probably her blood sugar comes very low by the insulin. So she had to adjust the doses of this insulin.
Yeah. Dr. Veena is asking, does fruit increase the sugar levels?
Yes, there are some fruits which high glycemic index, which increase the sugar, like mangoes, like dates, like grapes, and other fruits with low glycemic index, like strawberries, like berries, green apple. So yes, and also the amount, which is reflect the glucose load, is very important.
Yeah, true. Sarah has just replied, yeah, she is on insulin. So what do you suggest according to that insulin? She's taking insulin.
Yeah, she has to see her doctors to adjust the doses.
True, true. One more question. Serena is asking, my HbA1c was reduced from 8.9 to 6.9 in last 8 months without taking medicine. Should I wait for some more days?
This is very good, but she must be adhering to a very strict lifestyle. And if she left her diet, it will increase again. She is not cured. Okay, so she has to follow her HbA1c every 3 months and her sugars, because if she left what she is doing, it will raise again.
Yeah, it will come back again. Yeah, yes. True. Hala is asking, her HbA1c is also 11 and she is on insulin. I don't understand what's the point of challenge. I am not receiving any instructions or anything. Lala, I think you are missing your emails. Every week we are sending a health tip. And today we have sent one email. Every week we are sending an email for a health tip, and every week we are conducting the webinars in connection to diabetes. If you have any questions, you can ask in the mail, in the support. We definitely will be answering. Many people are doing that. She's saying, Dr. Hala, sorry, I'm just interacting with her directly. Laila, you have to check your spam folder because we are sending more than 10,000 mails to participants. And we see how many people have opened it, how many people have received it. So it's 85% they are receiving it. So if you are not receiving, please check your junk mail or spam folder and make it whitelisted so you will get it regularly. Yes, please. Any other question if somebody wants to ask?
Could I ask a question, Dr. Wilku, please?
Sure, sir.
Dr. Hala, I would like to take your advice, ma'am. Now, I'm 75 years old. Number one, I am on preventive medication of all types, which would mean blood pressure, blood sugar, and cholesterol. However, when I look at the various figures that you have pointed out for metabolic syndrome, I notice that I'm doing quite well, meaning that my waist is unfortunately 40 still. Nevertheless, I'm about 26.5 in terms of my weight. What would that be, Dr. Wilku? That is the not weight, but the other thing. Anyhow, that is whatever. My triglycerides is 130. My HDL is at 45. My blood pressure is at 110/70 at this point of time. My fasting blood sugar is 110. And the word I was searching for was BMI, is at about 26. So what it seems to me, Dr. Hala, but I need your confirmation. It seems to me that I'm being a good boy. I'm listening to my doctor. I'm taking my medicine. I am trying to manage my diet. I am going for my exercise every day. And with all of that, I seem to be within all the ranges. So would you say that, what would you say, Dr. Hala?
Yeah,
I would value your advice.
Yeah, I don't think you have a metabolic syndrome but I think you have impaired fasting sugar because your fasting is 110, so you are pre-diabetic. So what is your HbA1c?
My HbA1c, when I took it with the challenge, was 6.4, Dr. Hala.
So this is high. So you have to do also the postprandial. Most probably your postprandial is higher than your fasting. And because of that,
it's 140.
You do the glucose tolerance test?
I haven't done it, but I will take Dr. Wilku's help and get it done.
Okay. So I know you are not metabolic syndrome. You are mainly diabetes, pre-diabetic. But you are going
Dr.
very
Hala.
good. Very good.
And when I get back to Russell Khaimah, I will take the liberty of dropping in myself and taking your advice personally.
Welcome.
Thank you, Dr. Hala.
Thank you.
Dr. Hala, there is one more question. Dr. Sanam, she seems to be pregnant first trimester and she is suffering from gestational diabetes. My fasting is 100 to 115 and random post meal is controlled. She is on metformin 750 BD.
Excuse me, she's in her first trimester?
Yeah.
No, first trimester, we don't say it is gestational diabetes. Gestational diabetes starts from the second trimester, not from the first
trimester. Yeah.
Okay, so most probably her fasting how much?
Fasting 100 to 115.
Her fasting 215?
100 to 115.
110.
I can't, 115 or 125?
100 to 115.
This is high. In pregnancy, the fasting should be less than 95.
Yeah.
And what is about her HbA1c before pregnancy?
She has not mentioned about it. Dr.
Yeah.
Sanam, if you have checked your HbA1c, can you share, please? Not done. Okay, she has not done HbA1c.
Okay, so this fasting is high in spite that she is taking 750 BID glucovage. So maybe she will need some insulin help to control her fasting sugar.
Yeah, true. I think that's all the questions. I will just answer Laila Taha. Laila, we are having webinars on Friday because it's a time which we most of the people can attend. And anyone who is by chance missing any webinar, they can review the recordings. If you are a participant, you can log into your page, and under the webinars archive, you can see recordings of the previous webinars what we have done. And like today's webinar, you can see it tomorrow morning because it will be uploaded, and you can see it. If you are not a participant, you can still log into rackdiabetieschallenge.com, and under webinar archive, you can see all the recordings. I think that's over. Professor, over to you.
My pleasant duty to thank Dr. Hala for what the audience has mentioned is an extremely well explained, presentation of a very complex subject. Thank you so much, Dr. Hala. And my personal thanks, because I noticed that it was completely relevant to me, and I was able to put a number to each of the factors that you did. But I will again come over to Russell Khama and meet with you. Thank you so much for your presentation, Dr. Hala. Thank you so much. My thanks to all the participants. The questions were excellent. The questions went into great depth on a subject that is anyhow complicated. I truly appreciate Dr. Hala's presentation, not only of the pharmacological aspects, but also of the lifestyle, the simple tips that help us to live a healthy life and to overcome such a major problem. Thank you so much, participants. Thank you to our great presenter, Dr. Hala. Thanks to all my support team, led by Dr. Wilku, who I might tell you, I don't think I should mention this. I should really not mention this. But Dr. Wilku, at this moment, we are not quite sure whether he's come out of being COVID positive. So he is sitting at home all by himself, and he is conducting this program from there. Now, that is what you call dedication. Dr. Wilku was not allowed to come to the hospital by virtue of our hospital rules, so he will pass on the virus to his computer, but not to any patient. Thank you, Dr. Wilku. Thank you, Sade. Thank you, Saloni. And thank you for the great team from IT and RAC hospitals. Thank you all so much. Now we have our next webinar. Yes, there it is on your screen. And that's because of the efficiency of Saloni and Sade also in the back end. Oh, thank you so much. I noticed that I am the main speaker. Thank you, thank you. So I will be speaking to you from India, and I will be talking on the subject of exercise. And for those of you who are wondering, why should an old man talk about exercise? Then I would like to remind you that in my younger days, I was a sportsman of some repute, but I will talk about that during the webinar itself. We have me presenting exercise. Dr. Nitya, our Chief of Quality, will be doing the overall presentation, and Dr. Wilku will, as usual, be putting questions to the speaker. Now, that is on coming Friday, the 21st at 11 a.m. UAE time. Friends, thank you so much and have a great day. Thank you and goodbye.